who's a senior consultant endocrinologist at the GD Hospital and Diabetes Institute, Kolkata. Is the editor of the Williams textbook of endocrinology and honors in pharmacology and internal medicine during his MBBS days. And he has received numerous citations and awards and orations, has more than 100 publications in international and national journals, including the Lancet, BMJ, Diabetes Care, Diabetes, Obesity and Metabolism. And he's been a contributor author for Indian Insulin and Biosimilar Insulin Guidelines, API and RSSDI textbooks, reviewer in the Lancet Diabetes and Endocrinology, BMJ, Diabetes, Obesity and Metabolism, Diabetes Research and Clinical Practice, Diabetic Medicine, and Indian Journal of Endocrinology and Metabolism. He's been the principal investigator in phase 3 and 4 trials, chairman for World Congress, Diabetes Congress 2018, and the scientific chairman IdeaCon 2016, organizing secretary IdeaCon 2013, and the co-organizing secretary of IdeaCon 2012 and 14. So he would be speaking on the concept of time in range and the clinical implications, and also the role of the generation 2 basals. My privilege to invite Dr. Avdesh Singh from Kolkata.
Thank you, Dr. Sen Gupta, for the kind introduction. Thank you, Bansi Bhai, organizer of DIAC-Con 2020 virtual. It's a privilege to be among all of you. So my job is to take you through a new concept in treating diabetes with time in range. It's very exciting for interventional cardiologists, diabetologists. Now we have put a newer name to people, those who are engaging in intervention in diabetology, and good to see that, we have got something to offer to our patients as the, time passes by. Now, the point is whether, these are highly evidence-based is the point which we need to discuss and rediscuss. And if it is really, important at all, then what is the role of generation 2.0 basal insulin? So where does the basal insulin fits into correcting your blood sugar into time in range? So first, before I start, this is a Sanofi sponsored symposium, and so therefore that's my conflict of interest. However, the entire presentation is absolutely science and nothing to do with Sanofi itself. What I'm going to do is that let's divide this discussion into 4 parts quickly, and just overview of what is TIR. Let me, confess here that I'm not expert on TIR. I have got as a small knowledge as many of you may have. However, what I learned is that this is a new entity which is being discussed. But then again, with a caveat that there are minuscule evidence, it is still in the fetal stage to my eye as a researcher and scientist. So what all about is being discussed is that we have come from the, the triad of fasting, prandial, and HbA1c to now glycemic hexad, adding, glucose variability or glycemic variability into that picture as a prominent one of the index endpoint for complications of diabetes. But again, I would re-emphasize, this is the weakest link of diabetes complications till date. We have got mammoth evidence to conclude that HbA1c, fasting, PP is directly related with both macro and microvascular complications of diabetes. If you compare this glucose variability, this is still in the fetal state. However, this is emerging with the upcoming data. Now, if you add hypoglycemia into this triad, it becomes a hexad. As you can see, these are very interesting nomenclature with perhaps little less value, in the current scientific evidence. Now, we have also been taught that glycemic variability is related to increased oxidative stress. Of course, glycemic variability is related with hyperglycemic and hypoglycemic excursion. Needless to suggest that but then we don't have any, the great tool to actually lower glycemic variability. And if still you have got a tool, we don't have enough evidence at the moment to suggest that lowering glycemic variability would lower the complications of diabetes. From the hypoglycemic and hyperglycemic context, it is important, and we don't want our patient to either end up in a hypo or a significant hyperglycemia. And therefore, the entire concept of time in range came into the picture. Now, HbA1c is a crude index, and I have been to be a great criticizer of HbA1c when ADA, ESD, and ACE guideline brought HbA1c in their treatment panel to decide whether you need a monotherapy or a dual therapy or a triple therapy, because HbA1c is never a real-time glucose level of the index patient. It only gives you past picture. So I consider HbA1c as a past tense, and this time in range as a present tense. And of course, you will treat diabetes on the basis of present tense, not the past tense. We have experience in day-to-day clinical practice. Many of your patients comes back to you with a high HbA1c, with a reasonable fasting and prandial plasma glucose. So, by considering that his HbA1c is high, I'm going to increase the dose despite the fasting and prandial is good. Perhaps answer is no, because there are a lot of, issues if you really target HbA1c for the immediate management of the plasma glucose, whether it is fasting and prandial. However, it is also true that HbA1c gives you the past tense, and even if your blood sugar varied between very high to low, you may achieve the reasonable target. For example, if you are achieving, if you have tried to bring down HbA1c to less than 7%, you can achieve this by a three kind of road or pathway. Someone may have a very nice glucose excursion without hyper and hypo, and yet achieving HbA1c 7%. Someone can have a too much high and too much low, and still achieving the HbA1c of 7%, because that's the average of the entirety blood glucose in past 2 to 3 months, of which 2/3 contributed in the past 1 month and 1/3 by the past 2 months. So therefore, there are many ways to reach to 7%, but the entire target is to not to go into too much low and high, and therefore this concept of time in range came into the picture. The story goes back to 2019, and there were experts across the world, those who sat together, and at ATD 2019 this concept was carved out, and over the last 1 year now it has came into the limelight, and different guidelines in the world recognizing this importance of continuous glucose monitoring and time in range. But then, as I said, as a caveat, it is still in the fetal stage, and we need a lot to generate data to really go for all out with regards to the time in range. So what is this time in range? Quickly, that you need to have your blood sugar between 70 to 180, 70% of your in the 24 hours of your entire day. That's a very simple idea. Keep your blood sugar by 70 to 180 range. Now, if you're exceeding that range, then you have got two kind of hyperglycemia, level 1 and level 2. As you can see, 181 to 250 is level 1, and more than 250. The idea is not to cross the level 2 hyperglycemia. You may have even level 1 hyperglycemia, that would be fine, especially in those having a comorbidities or elderly people. But then you shouldn't go into this yellow range of level 2 hyperglycemia. Similarly, as you know, hypoglycemia definition has been brought down from 70 to 54 recently. Naturally, that's why there is a level 1 and level 2. Level 1 is between 69 to 54, and level 2 is less than 54. So the entire idea of this time in range is to have a real-time evidence of blood glucose ranging between 70 to 180. Now, these time in range varies with the different population, and this is how it was proposed, that you can see here in type 1 and type 2 diabetes. Ideally, you should have your time in range more than 70% of times between 70 to 180. And as you can see, this is more stricter in someone having a gestational type 2 diabetes with pregnancy. As you know, as we learned from the HAPO study, that every quartile of increase in blood sugar is associated with increase in perinatal complications. So therefore, the time in range concept is very strict for pregnancy, diabetes, and gestational diabetes, whereas it is again little bit flexible for those who are older or higher risk. So this is how the time in range is being discussed in the modern treatment of diabetes. Now then, why it is important? So as you can see that this data, as I said, very beginning, and I would like to re-emphasize that this is still in a fetal stage. It looks little bit intimidating that really if you are having a time in range, your risk of retinopathy is increased by 64%, nephropathy by 40%. This is not the real data. This data has been derived from DCCT trial, happened a couple of decades ago on the basis of that. So this is a epidemiological calculation of a randomized controlled trial. This is a statistics, not the real data, which suggested that with the TIR of 10%, you increase retinopathy and nephropathy. You can see neuropathy data. You can see there are two reference here, which is, this neuropathy data is in a CKD patient with 100 patients data. So the only one study here is with neuropathy, which was published in BMJ. So you can see here, open, and this is a data of 100 patients in patients with CKD. In CKD patient, HbA1c is never a great tool to look for. And this small study with 100 patient data suggested that time in range is associated with increase in neuropathy. So as I said, this is only evidence, and other these two, retinopathy and nephropathy, came from derivation of DCCT data, which was done with a glucometer, not by the CGMS. So this is still in a fetal stage, very simple. And when it comes to carotid intima media thickness, that's even a poor evidence for any hard endpoint outcome. Nevertheless, this is gaining momentum at the current point of time, because the fact remains is that TIR is the real-time glucose control compared to the HbA1c, which is past tense. So what are the global guidelines which has looked into this? And because of those data, as I said, which was a consensus at ATD in 2019, has been now looked upon. ADA has talked about this, but this is not also brought into the guidelines directly per se. And also, if you look back into the 2020 ACE guideline, they are recommending now, realizing that CGM could be a preferred option compared to HbA1c, as I talked about, because of many pros and cons associated with HbA1c versus CGM. Well, so this is what the guideline is talking about. Now, point is, how can we reduce this glycemic fluctuation or glycemic variability with the help of basal insulin therapy? Well, so in the past, we have seen, modern insulin basal analog in particular was associated with a significant reduction in hypoglycemic outcome with the evolution of modern insulin, from NPS to glargine U100 and detamir, and now then we shifted into the glargine U300 and the digludec era. Over the time, we learned that these modern basal insulin reduces hypoglycemia significantly. But then there is no difference in glucose control as such, even if you compare NPH, head-to-head study with glargine. We didn't have any evidence to suggest that the glargine actually reduces HbA1c better than NPH. But when it comes to hypoglycemia, these modern basal insulin has taken care of that fluctuation in glycemic variability and suggested significant lowering, in particular in the nocturnal hypoglycemia. Now, whether this has translated into showing any improvement in the complications of diabetes, we don't have evidence at the moment that suggests that the modern basal insulin reduces macro and microvascular complications better than the older insulin. So that's the most important point. This suggests that although these modern insulin has lowered glycemic variability quite significantly, but that didn't translate into further reducing the complications of diabetes. That's why I suggested that glycemic variability and complications of diabetes is a weakest link at the moment, to go a little far on looking after this part. However, the hypoglycemia reduction is, of course, the very important in taking care of your patients with either type 1 or type 2 diabetes. So now, when we come in the era of basal insulin 2.0, we are of course discussing about two modern insulin degludec and glargine U300. So this is a slide in front of you where 2 PK/PD study was conducted with the 2 insulin manufacturer, Novo Nordisk and Sanofi. These are the company-sponsored trial PK/PD studies of degludec head-to-head compared to glargine, done in patients with type 1 diabetes with a euglycemic clamp. And surprisingly, both this study suggested completely diagonally opposite result, while the Sanofi study find degludec 300 better than degludec U100, at least with regards to the glycemic variability. And in contrast, if you look into the Novo Nordisk study, they suggested that degludec U200 is better than glargine 300 with regards to reduction in glycemic variability. Now, the point remains is that you need to understand that in the Novo Nordisk study, it was degludec U200, which is not available in India, which was compared to glargine 300, whereas in Sanofi, it was degludec U100 versus glargine U300. There are a lot of differences between these 2 PK/PD study. I'm not going to detail, but as a clinician, we were surprised to see that how 2 different PK/PD study conducted by 2 pharmaceutical company went in opposite direction. Where is the science? So recently, very recently, in fact, a couple of days back, this paper came out in Diabetes Care, and this is not sponsored by either Novo Nordisk or Sanofi. They further did a PK/PD study and compared glargine 300 to insulin degludec U100, and this study find that glargine U300 had 23% lesser variability compared to glargine degludec U100. So that's an independent PK/PD study, not related to any pharmaceutical company, that suggested that degludec is having little larger peak compared to insulin glargine U300. So that's the first independent evidence that suggested that maybe glargine U300 could have a better lowering of glycemic variability. Now, as a clinician, this is for research purpose. As a clinician, we want to know whether this difference in reducing variability translates into reducing hypoglycemia. That's what, as a clinician, we are concerned. So let's look into how does insulin degludec compare to glargine U300 with regards to the glycemic variability. So we do have some small evidence, generated very recently. So this is very small data of 30 type 2 diabetic patients having CGM for 5 days, as you can see, and put into either glargine 300 or insulin degludec 100, and the timing range was the primary target of mean percentage of remaining between 70 to 180. And you can see in this study, both insulin was looking like a mirror image to each other. However, if you closely look, there is certain difference, especially in the nocturnal timing, and this data suggested that glargine U300 had a much better percentage of patients between 70 to 180, especially during the night time. And as you can see, the p-value of anytime hypoglycemia, nocturnal hypoglycemia, and severe hypoglycemia was significantly better in glargine 300 compared to degludec. But again, with a caveat that this is a type 2 diabetic patient study, and this is not a guarantee. If you want to do this kind of a study, please get it done in type 1 diabetes. So this can give you a hypothesis, but not an original proof with 30 patients data. The next study also came into the limelight with another set of 24 diabetic patients. Very small study. You don't expect CGM study to be a big study. So again, a smaller study, 24 study profile, and again, replicating those findings that nocturnal hypoglycemia seems to be significantly lower in insulin glargine U300 compared to insulin degludec. The third largest evidence, perhaps, is this one. This is a real world data called One Care, a study in roughly 100 patients. So this is much larger with regards to the CGM study. And this was presented at this year at EASD. And you can see these are the patients who were switched from conventional insulin to the modern basal insulin analog, either glargine 300 or insulin degludec 100. You can see roughly 100 patient data in each arm, so roughly 200 patients profile. Primary endpoint was having a percentage of time in range between 70 to 180, and here is the result in front of you. So when you look into the TIR, it basically remains similar, when you are comparing two insulin together. However, if you closely look into this data, it gives us a hint that during the night time, somewhere between 12 a.m. to 6 a.m. in the morning, the nocturnal blood glucose range was much better, between 70 to 180 in insulin glargine U300 arm compared to degludec U100. So that's one of the good evidence right now in real world setting. But then again, as you know, the caveat of a real world study giving us a hint that insulin degludec U300 is not at all inferior to insulin degludec. This would be my conclusion. I would not say that they are greatly superior, but I would say that insulin glargine U300 is as good as and not at all inferior to insulin degludec when it comes to bringing down the TR between 70 to 180 through these CGMs studies. Ladies and gentlemen, to finish my presentation, as I said, glycemic variability and time in range has been associated with significant fluctuation of blood glucose. I don't agree whether it is really related with diabetic complications, still in fetal stage. TR is important, but it is difficult to measure because we don't have every patient who are willing to go for a CGM or even SMBG with 7 to 8 blood glucose monitoring in a day. So difficult to practice, but then it's good to know how is the blood sugar in the real time manner. The second generation insulin 2.0 insulin glargine U300 and degludec, of course, has shown a better, flatter glycemic profile compared to the older insulin, and that's the reason why they have shown a significant reduction in the nocturnal hypoglycemia. And right now, the recent data, although in a smaller scale, does find glargine 300 may have little better outcome compared to the insulin degludec. However, these are the smaller evidence. We need to have a larger study, which is right now undergoing, comparing between glargine U300 and degludec with regards to the TAR in the randomized double-blinded trial. That will finally answer that X is better than Y or Y is better than X. Thank you very much for your patience listening.